Welcome back to Mathematics School. Today I'm going to discuss you about circulatory shock. I'll be discussing the definition, types, pathophysiology, stages of shock, and few words on management. So let us start. So, what is the definition of shock? Shock is a state of acute circulatory failure which results from inadequate tissue perfusion. So, when the tissues are not circulate, perfusion is inadequate, what happens? The blood flow decreases. This leads on to decreased oxygen, and that leads on to cellular hypoxia. And cellular hypoxia, if not addressed properly, will lead on to organ damage or organ dysfunction. For example, brain within 4 to 6 minutes, the dysfunction starts. So, what is shock? Shock is a state of acute circulatory failure due to inadequate tissue perfusion, leading on to cellular hypoxia. So, the basic thing is decreased tissue perfusion, decreased oxygen delivery, and what happens? The cells will shift its metabolism to anaerobic metabolism. That is, when the oxygen is not there, the metabolism shifts to anaerobic and it produces lactic acid. And the excess of lactic acid accumulates in tissues that leads on to metabolic acidosis. And metabolic acidosis is dangerous to tissues and it produces cellular damage. So that is the basic pathophysiology. Now we go on to the types of shock. We know that the tissue perfusion depends upon the cardiac output, and cardiac output is stroke volume into heart rate. So the cardiac output depends upon the blood volume. Second, the peripheral vascular resistance. So if any of these decreases, so that is the cardiac output decreases, the blood volume decreases, peripheral vascular resistance decreases, we can develop shock. So based on this, you divide the shock into various types. The most important is the hypovolemic shock. That is, volume decreases. So that is very simple. Suppose you lose blood in a trauma, that leads on to what is called hypovolemic shock. Volume is less. In acute diarrhea, burns, all these leads to hypovolemia, that is, volume is less. Second important thing is when the heart is not contracting properly, we have set the stroke volume into heart rate. Due to some, for example, there is a heart attack, myocardial infarction, or the heart is damaged. This leads on what is called cardiogenic cause. It's called cardiogenic shock. Third is called a distributive type. A distributive means the vessels, there is vasodilation. So what happens? The blood pressure, the perfusion pressure comes down. So that is called a distributive. It occurs in sepsis, in anaphylaxis, and neurogenic shock. All these comes under what is called the distributive shock. In distributive shock, the peripheral vascular resistance decreases, the vessels expand, the tone decreases. So the major causes, remember, they are the septic shock, anaphylactic shock, and neurogenic shock. We'll come to that. Then comes obstructive shock. For example, there is a block in the vessels, or a heart is unable to pump the blood due to obstruction. For example, in pulmonary embolism, you can get what is called a obstructive shock. Now we go into the major cause I was mentioned. If you take the majority is due to the major chunk is due to hypovolemic shock, there is blood loss. As mentioned, it is maybe due to hemorrhage, burns, and dehydration. So what is the mechanism? When there is a volume is less, there is a decreased venous return, decreased cardiac output, hypertension, tissue perfusion is lost. Then comes the cardiogenic shock. The heart fails as a pump. As we have studied, that it is a double pump, and the heart pumping action is lost. Example, myocardial infarction. When the heart is damaged, definitely. Or there is the heart rate is very fast. The heart is unable to receive the blood because the fast rate. There is some arrhythmias. Arrhythmia means the rhythm of the heart is abnormal. So here the pump fails. Heart fails as a pump, so it produces decrease in the cardiac output. As mentioned, decrease in the cardiac output, the blood volume, or peripheral vascular resistance. All these three things contribute to perfusion. The third important type is what is very important, the distributive shock. So here what is happening is severe vasodilation. You might have heard a patient is given penicillin and the patient falls to the ground, and this is what is called anaphylaxis. So it is a this on to hypotension, tissue, decrease in tissue period called anaphylactic shock. Neurogenic shock is a common thing when somebody visits a surgery department or seeing a surgery collapses. That is due to neurogenic causes about which we study. Because the tone of the blood vessel's tone is maintained by the nervous system, and when there is an abnormality, the tone is not maintained due to vasodilation. So mechanism is a decrease in the systemic vascular resistance, blood pooling occurs. So that leads on to decreased tissue perfusion. Then finally, the obstructive shock. Mechanical obstruction, as I already mentioned, the heart is a double pump. So suppose there is a block in the pulmonary artery. That is called the pulmonary emboli. There is a pulmonary embolism that blocks the vessel. Then there's another condition called cardiac tamponade. There is in a heart is covered by the pericardial tissue, and there is a sac is there. If it is filled with the fluid, that is called a pericardial effusion. Fluid in the pericardial sac that will prevent the dilation of the heart. So the fluid here will prevent the heart from expanding. That is the cardiac tamponade. So this is produce an obstruction typically, and they produce again decrease in the cardiac output. So what are the major causes or types of cardiac failure? The shock, hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. These are the major types of shock that you should remember. Then the shock goes through various stages. The initial period it is compensated, and you may not understand. You not be able to detect it. There is a compensated phase, then it becomes progressive, and finally it becomes irreversible. So these are the three stages: a compensated phase, progressive phase, and a irreversible phase. So in compensated phase, the most important thing, remember the increase in the heart rate. So pulse rate increases. For example, a patient following surgery, the heart rate increases. Pulse is increasing. This is an indirect indication that the patient may be going into shock, the compensated stage. There will be vasoconstriction because the nervous system will try to redistribute the blood in the vital organs by vasoconstriction in the periphery. So the skin becomes cold and clammy skin. You may have seen somebody with diarrhea. When there is a lot of fluid loss, the skin is cold. And there is an activation of the renin-angiotensin system. There is a neurohormonal systems are activated. And in this period, initially the BP is maintained. So heart rate increased, BP is maintained. That is what is happening. And you get a cold, clammy extremities. So that is the first stage. There is no BP is normal. Then what happens? The patient is going to develop hypotension. Then, as mentioned earlier, the lactic acid increases and the kidney perfusion. So what will happen? The urine output is a very important finding. There is a decrease in the volume of fluid called the oliguria. And the blood to the brain, the blood flow is decreased. So what happens? You get confused. So the patient may talk abnormally. So this is called the These are things that is in progressive stage of shock. Then the patient goes into what is called irreversible stage, severe organ damage. So the patient has renal failure, so renal shutdown, output come. That is very important. We are mainly looking at the urine output. So myocardial activity may come depressed. So and it may even develop a myocardial infarction because blood flow to the brain or blood flow to the heart is decreased. And if left untreated, the patient dies. So the important clinical features are first important. Then has initial period is a tachycardia or the heart rate increases. Then there is hypertension, cold, calm extremity. The one exception is the septic shock. Why in septic shock the skin is not cold? I already mentioned that septic shock is a type of distributed. So in distributed shock, what is happening? The peripheral vascular resistance comes down. That is vasodilation. So the skin will be warm in case of septic shock. Decrease urine output and altered sensorium. So remember these the very important findings. First is the heart rate increases, the BP decreases, the urine output decreases, and the patient will have altered sensorium. That is, these are the features of shock. Then the hemodynamic differences in hypovolemic shock, as you mentioned, there is a cardiac output decreases. The body will try to increase the peripheral vascular resistance. It's not very important for you. In cardiogenic shock, again the same thing, the cardiac output decreases, compensatory mechanism, vascular resistance increases. In septic shock, the vascular resistance is decreased. In anaphylactic shock, again the vascular resistance, because both these are vasodilatation is occurring. Vasodilatation or it is a distributed shock. So what is the management? So prevention is very important. Hypolemia should be prevented. The IV fluids, blood transfusion. In cardiogenic shock, you give drops. Septic shock, very important. Antibiotics, vasopressors. Anaphylactic, the drug choice is adrenaline. That is a very important thing to remember. And so the important points to remember, the most common type is hypovolemic shock. Early sign is tachycardia, late sign hypotension, hallmark is lactic acidosis. Hope it is clear to you. Stay tuned for further videos. Thank you.